Dr. Maddie here. So today we're going to talk about your initial eval with a patient. So on that first day, just remember your patient's going to be probably kind of nervous coming in. They probably have never been to pelvic floor therapy. So the goal is just to make them feel extremely comfortable and that you want to exude confidence that you can treat their issue, and you also want to connect personally with them. So when you invite them in the clinic, you want to greet them warmly, say hi if they have their baby with them, all the things, all your baby's cute. If you maybe know them already, or say you see they're from the town you grew up in, any little connection, any way you can connect with them is gonna help build rapport. So you wanna try to shoot for that right away, asking them some personal questions in between your regular eval questions. So I'm in my treatment room right now. What you're gonna do when you invite the patient in to your room, you wanna tell them what to do because they're just scared. They don't even know where to go. They don't know where to sit. So I just say, come on in, go ahead and take a seat in this chair over here, and then we're gonna just start by chatting first. All right, so that already is giving them some direction, calming their anxiety, telling them where to go. And then you're gonna just start with your subjective, and I'm gonna go through really in depth for maybe new clinicians to pelvic health. If you have experience in pelvic health, you probably don't need to listen to this portion. So we wanna know extremely in depth what's going on. So we wanna go through bladder, bowel, and sexual changes. So you'll already have the intake paperwork, but you never know if someone's not mentioning something even though they didn't put it on their intake form. So if they're coming in with leakage, don't just go, yeah, okay. If they're coming in with leakage, you need to ask all the questions. What have they tried so far? What is causing the leakage? Okay, they leak when they run. Well, how much? Is it your full bladder? Is it just a dribble? And do you notice leaking any other time? What portion of your run are you leaking? Is it the beginning? Is it toward the end? Is it always at a certain point in your run? Just all the questions. Don't be afraid to go super in depth, especially if they're saying something like, okay, they have constipation. What supplements are they taking for that? If they are, and what brand? Every single thing. If we miss one little thing, it can be the difference between us healing this patient and not. Of course, we're gonna have them for about 12 sessions, so we'll have more time. So if you don't ask all the questions that first day, that's fine, but we wanna try to get as much info as possible. So that subjective part, you're gonna chat for, it could be quick, if their issue's super minimal, maybe 15 minutes. If it's more in depth, you might be spending 30 minutes chatting about their subjective. And then you're gonna invite them to do a movement exam. I'm gonna go through what I do in an evaluation, and you can add to it, you can subtract, but this is just gives you a schema for what an eval could look like. Okay, so now I'm the patient. You're gonna ask the patient to stand up, so go ahead and stand up. I'm gonna do my clinician voice, but I'm gonna act out the patient. So what I want you to do to start is I wanna look at your spinal range of motion, because we know the spine impacts the pelvic floor and all the nerves that innervate the pelvic floor. Plus, a lot of these patients have low back issues. So you're gonna ask the patient to bend down like they're touching their toes, check spinal flexion. Also see if that induces pain. Spinal extension, is that more painful than flexion? Are they hinging at just one point? Is it all in their L3, or is it evenly distributed through their spine? And then you're gonna ask them the side bend. What does that look like? Ooh, is that causing sciatic nerve symptoms, or is it not? Is one way more painful than the other? Next, I like to have the patient stand on one foot. It's gonna be helpful for older patients to just look at their balance. And for pelvic health patients specifically, I'm looking at their pelvic bones and seeing if their pelvis is dropping. So If they're going up on one hip and their pelvis is doing this, you know they have some pelvic instability contributing to their symptoms. You may also want to look at their arch of their foot. Is their arch collapsing in as they're going on one foot? I like to have the patient take their shoes off before you do this part. And then check the other side, obviously. Maybe one side you're having some pelvic drop, some glute med weakness. Then next we want to look functionally. So I like to have the patient do 5 squats. And this is what I'm looking for. 1, are they leaking as they're squatting? How low can they go? Are they below this midway point? Are they just kind of up here? Are their knees, are we having some valgus? They're having some valgus. That glute med is weak, and that could be a big contributor to their pelvic floor symptoms if they're not having correct biomechanics with different movements. So really key in on those knees. Just a little bit of bowing in is a problem. You might see it just really quickly, like right there, or on the way up, or it might be really bad the whole time. Usually it's just real subtle. And then look for squat form. If they've never done sports before, they might be going like this, knees way over ankles. So just make a note in your chart that if they're doing that, that's something you want to look more in depth. If they're a high-level athlete, you might have them do a single leg squat. What's their knee doing again? Are we having some valgus? Is their arch collapsing? Is their pelvis wiggly? Is their trunk unstable? A couple other things with the squat I just remembered. You want to have a hinge with the squat. The chest can come forward. You don't want to just be straight up and down trunk. A hinge is normal with the squat. If the pelvis is nutating, you're tucking the tailbone, that's also not good, telling me that they have some stiffness in their pelvis. If at the very bottom of their squat, their butt is dipping like this. Dipping. We want to continue with functional assessment. So if your patient is coming in for leakage with jumping, I like to do a jumping progression and see where they have the leakage, and we can get some objective numbers from this. So usually I'll have them start by doing 30 jumps, just normal. If they can do that without leaking, I just mark in the chart 30 jumps with no leaking. If they pass that, that's kind of the middle test. Then I would jump right to the harder test, which is going to be jumping jacks. Can they do 30 jumping jacks without leaking? Having the legs in abduction is going to put a lot more strain on the pelvic floor. If they start to leak, note what number. So maybe on jumping jack number 14, they started to leak. And note how much they leaked. Was it just a dribble? Did it feel like it was just starting to leak, but they didn't actually leak? And the patient should stop jumping once they start leaking. That kind of ends the test. So it's either 30 reps or when the patient starts leaking. If they leaked in that one, we want to try to see where their threshold is. So if that was past their threshold, the full jumping jacks, maybe the next step would be doing scissor jacks. If they're leaking there, that means that's above their leakage threshold as well. So if they did regular jumps with no leakage, that's kind of like the highest they can go before they leak. So I consider regular jumps, scissor jumping jacks, regular jumping jacks. And then of course up here would be like really high level, maybe like if they do track and they're like long jumping or like hurdling. And then below just regular jumps, if the patient's already leaking with just regular jumps, you can test out some different things to see what helps minimize the leaking. And it'll tell you kind of what's contributing to their leakage. So the next thing I like to try, say they're leaking with just regular jumping, you're gonna have them squeeze a ball between their knees. Let's see if getting the adductors firing corrects their leakage. And then we know if we get the patient's hips, their hip muscles going through our therapeutic exercises, we'll likely treat the patient's issue if this exercise corrects their leakage. So now let's see if they jump while squeezing the ball hard, if they can do 30 without leaking. Say they're still leaking and they got 19 jumps, you'd mark 19 with the ball. And then I like to test, and this, you only do this if they failed like regular jumping. I like to do jumping with trunk flexion and support on the counter. So see if they can jump with the support. Can they get 30 jumps without leaking? Mark in their chart. And then the other thing is to switch their breathing pattern. So have them exhale every time they land. See if their breathing pattern is what's causing the leakage. Most likely it's going to be a combination of things. So adding the ball between the knees is going to help a little bit. Like they might get to 19 jumps, or like no ball, they were at 10. The breathing, they might get to 21 jumps. And so there's usually a lot of factors that play into leakage. So this time, each time the patient lands, you're going to cue them to exhale. So see how many they can do. Last one I just remembered, you're going to have them try to jump and land soft. So see how I'm landing. Nice cushion, bend in the knees. See if they can do 30 here. You might also notice as you're doing this test, as the test is progressing, they're leaking sooner and sooner. So that tells you also that's maybe more of an endurance issue. As they're jumping more, like they've already done 5 sets of 30 jumps, they're starting to leak more.